This is the BiPAP Focus. We use it to deliver bilevel non-invasive ventilation. It will deliver CPAP as well. However, it's not really useful for very acutely unwell patients because we can only entrain oxygen via green tubing, which you can see going into Jeff's mask here. So this is the tubing that we use. It's called passive tubing. It has a filter at the patient end, so we're filtering inhaled and exhaled gas. This is our exhalation port. We don't need the pressure line for this ventilator, so this pressure line needs to come off the circuit and we need to cap it off. So I'm going to pull that off the circuit all the way along and we're going to discard it. So if we make sure the exhalation port is at the patient end, so that fits snugly into the mask. Point that away from the patient, and then it's not necessary to have a filter this end, but the tubing comes with filters both ends, so if you haven't got a shortage of filters, then use the filter at this end as well. It's fine. We must make sure that filter's at the patient end. Okay, so we've got oxygen entrainment that goes into a flow meter in the wall, and we need to plug the focus in the wall too. There's a switch at the back that you need to turn on. So I'm just going to do that. And you can see your green lights come on. It does take a little while to warm up. And pre-COVID times, we used to leave the mask off the patient until the ventilator was blowing. But now we don't want COVID-19 spraying everywhere. So what we tend to do is put the mask on the patient before the BiPAP starts blowing. So this is our ST screen. This is our spontaneous time screen, which is Respironics terminology for bilevel non-invasive ventilation, or BiPAP. So it says mode ST at the top. So on the right-hand side, my right-hand side, we have machine settings, and on my left-hand side, we have patient data. So these are the things that we need to set. We have IPAP, which is your inspiratory positive airway pressure, and EPAP, which is your expiratory positive airway pressure. Those pressures will be medically led and will be decided prior to putting the patient on non-invasive ventilation. Although the BTS and ICS guidelines are excellent, and they'll guide you, depending on what condition your patient has, what kind of pressures you should start a patient on. Then you have your rise time. Your rise time is your rise to pressure, so essentially how quickly you're going to achieve your set inspiratory positive airway pressure. If someone is very tachypneic, then you want them to be achieving their pressure quickly, so you maximise your tidal volumes and blow off your CO2 and correct your pH. On the Respironics machines, 1 is the fastest rise time and 6 is the slowest rise time. So we recommend that a patient with a respiratory rate of over 30 should be on a rise time of 1 or 2. Then we have a rate. This is your backup rate. Your backup rate will only kick in if your patient doesn't take a breath within a preset time. So if, for example, Jeff's breathing at 15 breaths a minute, if her spontaneous rate dropped to 14 breaths a minute, if she hadn't breathed in for 4.5 seconds, then the machine would give her a backup breath. The I time is the inspiratory time for backup breaths. So if the ventilator gives a backup breath, then the I time, as set here, the machine will inspire for the patient for 1.2 seconds. If the patient doesn't fall below the backup rate, so if the patient is breathing at 16 or above breaths per minute, then they will choose their own I time for their own inspiratory breaths. It's only the backup breaths that the I time that we set here is important for. So if the patient falls below 15 breaths a minute, the ventilator will give a breath and the inspiratory time will be 1.2 seconds. Then we have our ramp time and ramp start. We don't want to ramp up our pressures in acutely unwell people, so we leave that alone. We need to make sure our ramp time is set at 0. If we want to change anything on the screen, we have to use our navigation accept keys. So if I go through the keys, this is your page change, this is your cancel, this is your navigate up, this is your navigate down, and this is your accept or OK button. So if we navigate down, go down to our IPAP, then we press accept. We want to change whatever the IPAP is. Then we use our navigation keys to change that. We say accept again. Thank you, that's what I want my IPAP to be. and the same for everything that's listed on the right hand side. You navigate to it, you press accept, you change using your navigation keys, and you accept it. So on my left hand side, we've got what the patient is doing. So we can see the patient at the moment is breathing at 16 breaths a minute. It tells us an estimated tidal volume, which is fantastic at the moment, at 1180 mils. It also tells us our minute ventilation. What's very important is the patient leak. So what we want is to minimise leak in patients with COVID-19, but we don't want the masks so tight that the patient's not going to be able to comply with it. It's going to be very uncomfortable. So we, in normal days, would have a leak somewhere between 7 and 25 or 35 litres a minute. In patients with COVID-19, to stop the spray of unfiltered exhaled gas, then we try to keep our leak a little bit lower if possible. But again, we want the patient to wear the BiPAP, wear the mask, so we have to have it for comfort as well as leak. This apnea reading essentially measures 10-second apneas per hour. It's not really important in general terms. It's if a patient is using their backup breaths, then it will measure all those backup breaths, those backup periods of time as an apnea. But we know the patient is ventilating well because they're on a BiPAP. If we go to the next screen, so if you press the change screen button, you can see that we have all the same patient data. I'm just going to reset the alarm. And we have apneas in seconds alarm, and we have an apnea per hour alarm. So it's important that we set the apnea per second alarm. So if our patient's having an apnea of over a certain period of time, that the machine alarms and tells us that that's happening. So it's already highlighted. So what we do is we press our accept button, and then we can use our navigation keys to decide how long we want it to be before the machine alarms. I would recommend setting it at 20 seconds. It will go 40 and 60 seconds. So if we just set it at 20 seconds, we press our accept button, and now we know if our patient's not taking a breath of their own within 20 seconds, the machine will alarm and tell us. If we go to the next page, there's all manner of things like how bright do you want the screen and how loud do you want your alarms, and you treat all of those things in the same way. You use your navigation keys to highlight what you want, you press accept, and you can change whatever the parameter is using your navigation keys. Press accept to change. Now if we go back to our page change, we go back to our original screen. So this bar here tells us what pressures that the patient is achieving. So at the moment we've got an IPAP of 15 and an EPAP of 4. We're achieving our EPAP of 4. We're not quite hitting our IPAP of 15. Jeff's now taking a nice big deep breath, and Jeff's got nice compliant lungs. So it's not easy to hit your positive inspiratory airway pressures. Okay. The other thing that I should mention is your trigger. So at the bottom of your patient data, it tells you whether your patient is triggering the breath or whether it's a timed breath or a machine breath. So if the patient isn't triggering the breath, it will say timed instead of patient. To turn this ventilator off, you press the button in the bottom corner, and you have to navigate to OK, and press OK. And then you take your patient's mask off.